Mrs. Williamson, hello. Pleased to meet you. My name's Dr. Galloway. I'm one of the junior doctors on the team. So, I wanted to have a chat to you this morning about your husband, Mr. Williamson. First of all, because I've not met you before and spoken to you at length before, what do you understand at the moment about his condition?
Well, it's not technical terminology, but he's got cancer in his lungs for some reason, and really he's not going to get better. They can't do any more, and it's waiting now.
Has anyone given you any idea of how long, or...?
Well, no, people are always very vague about that, but then I suppose you've got to be. I guess when we came into hospital this time a week ago, they said it was to try and sort out his pain relief, but I think we probably both thought he wouldn't be coming home.
I think that's true. He has got advanced cancer, and I think our main aim now is to control his symptoms. And I think it is always very difficult to give any idea of time scale, and I think it's impossible to do, but I think we are talking days or weeks rather than anything longer than that. With regards to his care now, what are your particular worries? What are your concerns?
I think that since he's been in, he's changed quite a bit. Sometimes he's lucid and I can have a conversation, but a lot of the time he's very restless, and he then is not lucid, and he's hot, I can't really talk to him. And I think that I'm worried that his pain is not being controlled, because I assume that the restlessness is the fact he's in pain.
I think we've noticed he's deteriorated on the ward as well, and I think we've been having the same concerns as you. At the moment, his pain control has been managed with a morphine patch and then oral morphine as a top-up in between times, but I think we are concerned that we're not adequately controlling his pain as well. I think the agitation and the restlessness may be partly the pain, although that sometimes can happen as a feature of cancer as it becomes more widespread.
Yeah.
One potential option now is that we can, instead of using patches and oral solutions to treat his symptoms, we can actually put him onto an infusion, onto a drip.
Yeah, that was actually one of the things I was going to ask about, because he doesn't seem very happy about swallowing food and even drink now, and it's getting difficult. I had wondered, and I was going to ask you, he won't eat anything at hospital, and I don't know whether it's because he's going worse and he can't swallow as well as he did, or whether it's he just doesn't fancy the food, and I was wondering if I could possibly bring some soup in or something that I've made at home, whether at least that might tempt him.
Of course you can, and I think if he wants to eat it, that's fine. One of the stages that people go through as they die from cancer is that they do lose their appetite, though, and that people often, it's not that they can't swallow, they just don't have any desire to eat or drink.
Yeah.
What I propose is that while we're looking after him like this, we should introduce a series of medications we can give through a drip. That way he doesn't have to swallow. He
Yeah.
can take things by mouth if he wants to.
Yes.
But that we can give him all
Yeah.
the medications for his symptoms.
Yeah.
And it doesn't have to be a drip into a vein. It can just go under the skin, so it doesn't need him to have lots of drips put in and out all the time.
No.
And I think we probably recommend that we start on 3 different types of treatment. One treatment specifically for pain, but I'd also introduce a treatment for agitation and also treatment for sickness as well, and we can combine all of those into one drip. And then there we can also change the dose of that on an hour-by-hour basis, so that if we think he's not controlled, we can increase the pain relief.
I suppose I'm quite surprised. I mean, you've said he's getting to the last perhaps few days or few weeks, that the pain is so hard to control. You know, you see on television and in magazine articles these days that it says that nobody needs to die in pain, and I think this is the biggest shock to me, because I just think that the last weeks somehow the pain doesn't seem to be helped as much as we'd hoped.
I'm very sorry that he is in pain, and I'm aware of the articles in the press about that, and we strive for that, and I believe that if things go well, we should be able to treat someone's pain completely.
Yeah.
That said, his pain has got much worse very quickly. I think we didn't discuss this when he talked about why he'd come in, but he's had a break in the bone in his spine, which has made the pain much worse very suddenly. We're treating him with a morphine patch called fentanyl, and that patch lasts for 3 days, as I suspect you're aware, and so it takes a few days to then put a new patch on with a higher dose.
Yes, yeah.
And I think we have been slow in catching up with his pain relief, and I'm sorry about that, but I think we can do better.
Yeah.
And I think that if we change him to the driver, to the drip, then we can get him in a much more comfortable position.
Yeah.
Are there other issues that are on your mind about?
Well, yes, there is, and I don't know how to say this, because you're going to think it's terrible. Is there any way it can be speeded up?
That's a very difficult question for me to answer. I think...
You think I'm dreadful, don't you?
No, and I've been asked the same question before many times, and the thought's one that crosses all of our minds when someone
You know,
is
if you love somebody, it's dreadful seeing them like this.
I think there's 2 sides to this. One is that there is a very definite law in this country that we cannot do things to bring about someone's death.
Yeah.
But at the same time, I think we must do everything we can to keep people comfortable. And I think in some ways, actually treating someone's symptoms potentially can hasten things, because as someone becomes more drowsy from the medication we give to treat the anxiety or the pain relief, they do sometimes drift off to sleep. And I can't say how long it'll take.
No.
And I can't guarantee that I can do something that will mean this will just be a day, and it may be several days or longer. But what we can do is make sure that your husband's not in discomfort during that time, and I think I can't do something that's going to with the intention of speeding things up, but I think in some ways what we are going to do may hasten things, and
I mean, he's we've signed this thing that you know that you don't try and bring him round if.
Yeah.
And I mean, we both sort of accept. At the time, I have to admit that I didn't so much. It was my husband that wanted that, but now I'm glad he's said that. I just want it to be over for him. See, I've said I'm worried about him not eating and about bringing soup and things, and then the other half of me says, well, if he's not eating because he doesn't want to, will that bring the end on a bit faster if he's not eating? I don't know what to think anymore.
I think regarding food, I think regarding all of his care, we take the same approach. If he's hungry and he wants to have a little bit of soup that you've brought in, then I think we should give him that.
Yeah.
Because I think our goal is to keep him as comfortable as possible. I don't think giving him food and water is about giving him nourishment, because I think as the end does approach, that's not going to be an issue.
No.
I think we need to be very careful that we don't let his mouth get dry, and the nurses are very well trained here about making sure that his mouth is kept moist, and we do all the sort of the oral hygiene measures.
Yeah.
And if he's thirsty, we will give him a drink. But if he's not, then I don't think there's any reason to. And if he starts to become unconscious, we wouldn't start putting up a drip or start giving him feeding through a tube. I think we would let nature take its course when that happens.
Well, thank you very much. The only other thing is, I mean, he's now been in hospital and he's been treated for this for ages. When he dies, he won't have to have a post-mortem, will he? It'll just be the end, let him be.
Right. There's not actually... I'm not going to be requesting a post-mortem on him from a hospital point of view. He's got mesothelioma. Do you know if he was exposed to asbestos in the past?
Well, he probably was, because he worked at the docks for all his life.
Right, okay. Do you know anything about asbestos and mesothelioma? Has anyone ever spoken to you about that? Did the oncology team, the cancer doctors, speak to you about that at all?
No, not really. I mean, we know there's been stuff in the papers about it.
Okay. I think we ought to have another meeting about this. People who've been exposed to asbestos are at risk of developing cancers like mesothelioma. In fact, it's very unusual to develop mesothelioma, the type of cancer your husband has, unless you've been exposed to asbestos. And because that makes it a work-related condition, it does need to be reported to the coroner. But that doesn't mean it needs to be referred for a post-mortem.
No.
And we will do everything we can to respect your wishes. I'd like to sit down and chat with you again, but maybe I could ask one of the nurses from the Macmillan team to spend a bit of time with you, because I think you've got quite a few questions, and that we can make sure that the treatments we're going to change work, and that your husband is feeling better because of them.
Yeah.
So if I ask one of the Macmillan team to come and speak with you this afternoon, would that be okay?
Yes, because I'm here all the time. Just want to be with him.
Regarding the post-mortem, let me speak to my consultant and get some more information about that and exactly what we can do to see that that's avoided if at all possible.
Okay.
Like I say, because there's this history of asbestos, we probably will have to report it to the coroner, but that doesn't necessarily mean he'll need a post-mortem. And if we make it very clear what your views are, that will help.
Right.
Okay.
Thank you very much.
Okay. Thank you very much.
Okay.
Bye-bye. So this is a discussion related to Mrs. Williamson, a lady whose husband is in the palliative care unit with metastatic mesothelioma. There are two particular points raised in this scenario. First of all, she raised the question of, is there anything that could be done to speed up the dying of her husband? This is a very challenging situation to be in from the doctor's point of view, because for both family and for medical staff it can be very upsetting watching someone dying. But at the same time, we must stay very much within the bounds of the law, and so our treatment must be aimed at palliation. You cannot instigate a treatment with the intention of speeding someone's death. However, I think for the exam it's worth being aware of this intention of double effect, that you may prescribe a drug with the intention of relieving fatigue or pain, but that you know that may in its own right speed up the death. But the initial reason for prescribing it was palliation of a particular symptom. The second issue raised here was about the fact this gentleman had mesothelioma, and mesothelioma is nearly always related to asbestos exposure. And if you suspect there might be a work-related cause, then this is a case that will have to be referred to the coroners. Not necessarily for a post-mortem, but certainly for their opinion, and maybe a post-mortem. That wouldn't be up to the treating clinician. Always be cautious when you get faced with a case in an MRCP. Always look for the little facets of the case like this, like, is it going to be an occupational issue? Just in the same way, the person who's had a syncopal episode, do they drive a taxi, for example?